I've got a few questions, but I'll only ask one in case there are lots of others. Just a question for Sarah. The iodine, because I agree with you on that, but does it affect the commensal bacteria at all?
Can you hear? Is that working? Yeah. The joy of both iodine and vitamin C is you take them from the mouth, they kill the microbes in the upper gut, and they're then absorbed. And they're largely excreted in the urine, so they don't upset the friendly microbes in the large bowel. If you take too much vitamin C, then yes, some does spill over into the large bowel. It will start to kill some of the friendly microbes, which then get fermented by other fermented microbes to give foul-smelling wind. And that's the definition of bowel tolerance. So if you take so much vitamin C or iodine that occurs, then you've overdosed. But no, it doesn't upset the friendlies in the large bowel.
Thank you.
Okay.
If no one has,
You don't need to pause.
I have other questions, but in case someone else.
Okay, well, I'm going to take a Zoom question now. So we're sort of taking it in turns between live people and virtual people, as it were. So this is a question that any of you could answer, but I think probably best Dr. Myhill again. When is the best time to test the thyroid? Is the morning best? And if it's a woman, does it matter where she is in the menstrual cycle?
No, I don't think it's that critical. But the point about the blood tests for thyroid function is they just give you the course tuning. And if somebody is running, we all have our own personal reference ranges, which are not the same as laboratory ranges. And if somebody has got typical symptoms of an underactive thyroid and they're running towards low end of range, then there is clear scope for a trial of thyroid hormones. And the key is start very low, build up very slow, and monitor clinically with pulse rate, blood pressure, core temperatures, and of course how you feel. And done like that, it can be done very effectively and very safely.
Thank you. Another question from the audience here? Yes, lady at the back. Right, the roving mic is on its way to you.
Hello, thank you. Just a question about melatonin to Dr. Yassin. Can you expand or to the panel?
Yeah, can you speak up?
Yes, sorry, is that better? Just a question about the melatonin that was mentioned earlier. Dr. Yassin mentioned it. Could you give us some idea about dosing? Because I know, obviously, melatonin has lots of anti-inflammatory properties and it's used in many ways. I think there are restrictions around the use of melatonin. But yes, what would be a dose above the 2 milligram that is used with Circadin, which I think is probably a little bit insufficient? If there's any sort of enlightenment on that, thank you.
Yeah, thank you. So I tend to start with a low dose and see what the patient would tolerate. So for instance, 1 milligram even works in some patients. You don't have to necessarily notice the sleeping effect until you still achieve the anti-inflammatory and the antioxidant effect. But typically I tend to prescribe between 3 and 5 milligram. That's for my long COVID patients, I'd say.
Okay, thank you very much. Now the next question on Zoom is addressed to the whole panel, so anyone can answer. What are your views on, and I think you mentioned this in your presentation actually, what are your views on selenium in long COVID? And they've written contributory factor question mark. I presume they mean is selenium deficiency a contributory factor rather than is selenium a contributory factor? Anybody want to answer that?
It's a Daniel question.
Okay.
Is it? Can you give me that last bit again?
Well, all that I've got written here from the Zoom question is, what are your views on selenium in long COVID? Contributory factor question mark. So whether they mean is selenium a contributory factor or is lack of selenium a contributory factor, I assume the latter. It's what the immune system needs, isn't it?
Well, yes. Selenium's got two obvious roles. One is as the mineral cofactor for the antioxidant enzyme glutathione peroxidase, and the other is as a mineral cofactor for thyroid. So there are two ways that can be important. It's also got an important role in acute COVID, where it's been shown that areas of low selenium are areas of rapid mutation of the virus, because it's one of those things that, what doesn't kill you makes you stronger. I'm talking about the virus in this case. So if the virus can't protect itself, it has to mutate to do that. So that's also a reason why you give people with the acute infection selenium. But I think it's, yeah, it would naturally be part of the package, part of the stack, as people call it, for long COVID.
Okay, thank you.
Any advance?
No, I think that's it.
Okay.
Anybody else? Another question from the audience, Wendy. It's all right, Rachel. She's
I've had a number of questions and thoughts, really. I'm sure everybody else does. I know we don't want to talk about vaccines, but I did wonder if anyone, Rachel, probably in particular, whether you'd found any studies for long COVID where people had not had the vaccine as well. I would be interested in that if you've been able to, during your sort of, you know, things, see any studies, because all the ones I've seen and all the groups I've seen have been people where it's a mixed bag, and I haven't seen any independent of where the two groups have been separated. So I would be interested in that. Maybe you can answer that when you're next on stage later this afternoon, if it's possible. I probably coming up from a week of trying to get hold of a GP for my daughter, and would like some thoughts from people. I mean, it's all very well looking at this long COVID, and I bring it up mainly because I am a GP, and I'm really clear that I would really like people in this audience to pay attention to what's being said, because these patients are not going to get into the GP, and this is my real concern, that it's going to fall to people that are in this room to be looking after these people. And I really want to emphasize this. I know how to negotiate the system as a doctor, and I find it almost impossible to get my children seen, even in acute situations. So how people with long COVID are going to get to where they need to get to, you know, an hour on the phone and no one answers the phone, you know, GPs won't bring you in. They want you to send photos of what's going on with you. I think this is what's really going on the floor here. And I just really want to emphasize that today, really, as a doctor who's kind of ashamed of where the profession has got to, actually, with all of this. I do really feel that. I feel it's, you know, it's not how I was trained, and it's not how I would like this profession to be functioning. And I feel embarrassed, actually, as a doctor. I mean, one could argue that it's great for business because I'm a private GP, but truthfully, I didn't go into medicine to not look after people properly.
Wendy, are your local GPs all working for an American company now? Because all ours are.
They are, indeed.
right. Anybody else on the panel want to respond to that? Okay, I'll go to another question from people on Zoom. It's for you. Which lab do you use for T-spot COVID testing? They mean T-cell. And can appendicitis be part of long COVID?
Yeah, I think this is what, yeah. I think it's good questions. We try to identify labs which are suitable to measure not only the acute response, but also the long response. Many patients do not develop antibodies for quite a long time. We are faced with this question. People want to travel, want to have test documentation to show they have recovered. They have a test that shows that they are, of course, they are alive when they turn up at the border controls, but they want to show that there have been positive tests and a T-cell response. So we use Armin labs, for example, in Germany. There's a lab in Oxford that measures the early phase response. There are probably other labs surfacing soon, because it's a diagnostic scenario. We'd like to get guidelines as practitioners also how to advise our patients, and in that respect, I feel it's also important that we can say the presentation of serious illnesses like appendicitis and so on, can that be attributed to to the causes that we discuss here. Mast cell activation, inflammatory signs that are driving what we know from conventional medicine are the typical presentations: pneumonia, appendicitis, inflammatory conditions. And will that be recognized also by the specialists if we venture into this kind of area of immunology? There will be a debate going on between specialists and sort of more pioneering researchers and practitioners. And I think the acute appendicitis need to be dealt with in the way it is and cannot be, there's no need for delays. And you have to deal with the acute presentation symptoms, then deal with the chronic. It has to be in the right sequence, in the right order, in terms of proper differential diagnosis, because the risk is now long COVID is just the scapegoat now for so many other conditions which could easily be missed are something else. And we just now call this long COVID, refer to someone, and there's no referral pathway that works. So there will be unexpected delays happening, which we don't want. So we have to think also in the way we were trained as physicians, as practitioners, and use the proper differential diagnostic exclusion criteria and algorithms to then come to conclusion of COVID or long COVID or long haul and think in that order. I think in that way we will get a recognition for this by establishment, by our colleagues, and laboratories will support us with this, I hope.
Thank you very much. Thank you. It's a really good full answer. All right, another question from people here. Somebody at the back over there.
Hello. Could I ask about coenzyme Q10 and about?
Can you speak up? Sorry.
Can I ask about the coenzyme Q10? Obviously, routinely thinking about people that are on statins in an older audience, but in younger clients that have got fatigue, particularly long COVID fatigue afterwards.
Okay, so about the use of CoQ10, yeah, coenzyme Q10. Who wants to take that? Sarah?
Well, when we did our study of mitochondrial function, coenzyme Q10 levels are almost invariably deficient in people with fatigue syndromes or long COVID or ME. So it's such a common deficiency that nowadays I don't even bother to measure it. I just recommend 100 milligrams CoQ10 as a routine. And so long as you've got a non-fermenting gut and you're eating some fat, you will absorb that and blood levels will come up reliably well.
Okay. Thank you. Another question from people on Zoom. This is actually 4 questions from one person, but they're all very short, practical prescribing questions, and they're for you, Dr. Bendi Abdallah. I'll read them each out and then I'll read them again, so you can do one. What dosage of glutathione and NAC, that's N-acetylcysteine for long COVID? How do you treat mucous membrane symptoms? How to prescribe low-dose naltrexone as a pharmacist? Dr. Michael Cannell said, I cannot prescribe this because of medical indemnity issues. And finally, what source might be recommended for transfer factors? So starting off with the dosage of glutathione and NAC.
Yeah, so I assume it's oral. I mean, if oral, I usually go for liposomal glutathione,
Right.
and 600 milligram as a minimum. So 1200 in some cases with patients that are able to do IV, as Dr. Sarah mentioned on the fermenting gut, sometimes it can be an issue even with the liposomal formulation. So it's good to have that option. There's even a nebulized form that you can have, and it's about the same strength, but with IV you can go a bit higher. We go to 1200, maybe even a bit more. NAC is about the same, so I just use usually oral formulations, and sometimes we include in the IV 600 milligram. With
I'll give you that.
Okay. So in terms of prescribing, so low dose naltrexone, as a prescribing pharmacist, is something that's it's an off-label indication, so you're able to do that. you know, it's the same thing as, you know, prescribing, for instance. You know, there's some medicines that you can prescribe for an off-label indication, so it's not, you know, it's a compounded thing. So I don't think there's any issue for indemnity. I haven't, you know, it's not something that I've experienced myself. You know, and it's a very safe medicine to prescribe. Minimum, if any, side effects. I mean, if anything, you know, if when you start very low, patients start telling you, you know, I'm not seeing anything, but it's not something that you just, you know, it's not a painkiller as such. So, and that's why the build up. And there's lots of info online. I think there is the low dose naltrexone society. So they've published protocols for practitioners. They're available for everyone online. So, you know, I'd say if someone is a prescriber, you know, they've done their studies, they can back their learning, then, you know, they're absolutely fine. And transfer factors, I mean, I like to use, you know, the brands I mentioned, Mott's Messenger, which I think is from colostrum extract. And, you know, I've come across some other companies that do transfer factors, which are a bit more bespoke. I've never experienced that. So it's based on the condition. I don't know if anyone has, there's an American company, so it's they would make it depending on what's the. But I think, you know, the ones I've used, for instance, from colostrum extract, at least from Nutriad, they do the job with the patients I've treated. So.
Okay. Thank you very much, Damien. Do you want to add anything?
No, I don't think
No?
so. Really.
Okay. All right. Thank you. Another question from our audience. Yes, go ahead. Well, when somebody brings you the mic. It's all right, Rachel. Sarah's got one nearer. Hi.
Thank you. It's just the practicalities. I'm not a doctor, but just in terms of recommending IV or ozone therapy, is there somewhere in London, for example, that you might suggest, or your clinics, that we could recommend people to come for these sorts of therapies?
Who would like to? Do you want to? Or
I don't prescribe them myself, though I do know of therapists who can offer them. But I think among us here, you know, it's probably not too difficult to make suggestions. Ziggy, you do them, don't you? Yeah.
Well, you asked about London. I don't know the situation in London. I'm living 50 miles outside, but there are a number of practitioners who use ozone treatment. Yeah. And so, you know, so ozone treatment as part of the oxygen spectrum of oxygen treatments. There's hyperbaric, there are a number of different modalities of administering oxygen. Ozone is often considered as well this very potent antiviral, sort of wipes out everything, but the practicality is also, you have to find someone who can tolerate having a large cannula in their arm if you do ozone hemoperfusion, which is quite a technical procedure, and you have to have various safety measures in place. It's not something you can just do at a corner shop somewhere or in a backstreet garage, so it's for that reason often expensive. It needs to be regulated. There's also external applications like leg ulcers, for example. So dermatology clinics, there's a real chance for them to pick it up for like diabetic or gravitation ulceration of legs. And also ozone, you mentioned Dr. Yassi, but there's rectal insufflation, but these are all slightly, you know, sort of looked upon by the general establishment immunologists as slightly pioneering sort of treatment modalities that you have to somehow as a practitioner have to defend and have to find the right indication spectrum, what patients are suitable. So it's not a treatment that is absolutely miraculous, could put on some websites and so we get rid of the virus that way. So I have to sort of give you a bit of a
handle with care.
Handle with care, yeah.
Do you want to add
No, I don't really, because I mean, you said, oh, there's a variety of different modalities, aren't there, of doing this. You do need, you know, to know what you're doing, as you said. I think you're right. I'm starting to work on using hyperbaric oxygen with phototherapy to open up the circulation. And so I think that's going to prove a good combination. But, you know, there's a lot of them.
Thank you. Okay. Now, here's another question from Zoom. How long, for the whole panel, how long after initial infection could long COVID be diagnosed? 1 year, 2 years, 3 years? Is there a cutoff where it should be assumed to be something else?
Can I?
Yes, go ahead.
I mean, I think it's pretty arbitrary, as shown by the variety of criteria used in different studies. Arbitrary as to when you, at what point you can say it begins coming long COVID. As to when it stops, well, there's a slide that I decided not to use in my talk this afternoon, which I kind of wish I had, which was from the neurologists looking at effects after brain injury. And what it basically says is that it only needs one traumatic brain injury. So, you know, like a concussion or whatever, to give you overactivation of the microglial cells that you were mentioning and so forth. And this has been documented as still being visible after 18 years. So I don't think there's any reason to say, oh, after X time, it's got to be something else.
And I'm sure we've all seen patients with reactivation of Epstein-Barr virus that they had 20 years ago.
Yes.
So, you know, you're never out of the woods till you're out of the woods. Yes. It's all right.
Thank you.
Thank you, Sarah.
Just a quick question. What's the situation with copper zinc ratio or problems in long COVID?
Copper zinc ratio problems. Gillian and then Ziggy.
Yes, I'll be talking a bit about that this afternoon. Copper is bioavailable copper, that's Cu1, is absolutely vital, actually. It's very, a little bit neglected, let's put it that way. I'm doing some studies with, well, have been since becoming aware of him about 6 years ago in Seattle with Morley Robbins. And he's got a very, very specialist sort of niche interpretation of this, which is actually very broadly available on the web. You don't have to do a sort of extensive course with him, but absolutely fascinating. I'll be talking about how many different complexes in the mitochondria absolutely need copper in order to actually be able to activate the circulation of iron. And because hypercoagulation driven most likely, I mean, in many cases by the oxygen, the oxidative species from iron, which has got trapped in the cells, hyperferritemia. I'll be talking about how there are over 400 studies on hyperferritemia in COVID. So I think that this is something that mustn't be neglected at all. Hugely important, even for the thyroid. Yeah.
Thank you.
Yeah, I probably don't have that much more clever things to add, but I think it needs practitioners that are able to look into the trace element imbalances, who are aware that there are very subtle factors that could tip the whole balance, and it could be the zinc copper ratio. It could also be the iron levels, iron storage, and there's also a risk of copper being deposited, iron being deposited in vital organs, liver, lungs, and that's very much in the domain of general medicine. But there are also modern diagnostic tools. Some are here very familiar with oligoscans and capillary blood flow analysis using spectrometry. Modern technology is used to get quick results, which are relatively inexpensive. Again, there are specialists here in your lunch break. You can talk to them. That will help also nutritionists and complementary therapists to advise their patients correctly and to not randomly subscribe on a long catalog of supplements, to be specific, to to be right to the point, to be accurate. It sometimes takes a bit longer to get there, but instead of, randomly buying supplements, may not be the answer. So try to be specific, try to be analytical in the process, and the patient feedback is so wonderful to get, to help us to be guided in this process. Yeah,
Thank you
sorry
very
to
much.
talk so long.
Okay, no, that's fine. Okay, so now we've got some Zoom questions, and they're all for you, Dr. Myhill. I'll give them to you one at a time. The paleo keto diet and people with mental health issues. I have clients who had to stop the PK diet because it affected their mental health.
Well, actually, if you look at the work of Karl Pfeiffer and Abraham Hoffer, you'll see that the ketogenic diet is the starting point to treat many mental health issues. And I can only think that one of the things, when we put in an intervention in place that is effective, the body starts to react. Now, the homeopathic doctors call it a healing crisis. I call it D reactions: diet, detox, and die-off reactions. And it means that there is not a nice, smooth path to recovery. It's always a bumpy ride. So my guess is that your patients are experiencing the bumpy ride. But as I say, the ketogenic diet will reverse psychosis, for example, and we have lots of case histories and studies to show that that is the case.
Okay, thank you. The challenging questions continue, Sarah. I have seen people developing GORD, that be gastroesophageal reflux disease, while following a keto diet, and also having difficulties dealing with a high fat diet. Your views and advice, please.
Well, GORD, gastroesophageal reflux, is almost, I think, pathognomonic of the upper fermenting gut. It's and if somebody has got reflux or heartburn, they've almost for sure got fermentation there. So don't know what the clinical details of, but the treatment of that would be a ketogenic diet. So you don't give those microbes the substrate with which they can ferment. Another possibility here, of course, is that we need an acid stomach for normal gut function. And if the stomach is not sufficiently acid, then the pyloric sphincter, the plug hole of the stomach, won't empty. And of course, that will, as a prelude to GORD. So it may well be that that patient could be helped by taking acid supplement, betaine hydrochloride with the meals. Now, again, with the upper fermenting gut, you have a leaky gut. And with a leaky gut, you cannot concentrate hydronides. You cannot concentrate acid in the stomach. And so it might take a little while of a paleo diet or keto diet for the lining of the stomach to repair and heal, and then acid can be concentrated. The point here is you don't have to take betaine hydrochloride for life. It's just a window of time until normal function is restored. Now, what you're going on to say about many people don't tolerate fats, yes, that is a common problem. And that is simply because, we have become fat phobic. And suddenly, for some decades now, a low-fat diet has been the answer to preventing and treating all diseases. But the body is intelligent and conservative with its reserves. And if you're not eating fat, then it's not going to produce the pancreatic enzymes, and it can't produce the bile salts needed to digest fat. So the key is, again, you have to start slow and build up gradually. And if you're really not tolerating fat, then take digestive aids, which might include pancreatic enzymes, it might include bile salts, or possibly magnesium carbonate to help alkalize the upper gut. But that needs to be done 90 minutes after food. So digestive aids are often helpful, and a very helpful test is often a comprehensive digestive stool analysis, which gives us a handle on that.
Thank you very much.
Can I
Yes,
come
go
in on
ahead,
that
Damien.
bit? Yeah. Well, I wouldn't dare disagree with you at all, Sarah. But the other thing about not tolerating fats is this. The digestion of carbohydrates and proteins is pretty much finished when the food leaves the stomach and goes into the small intestine. It's mainly for the digestion of fats that you need all the other stuff, the enzymes and juices from the pancreas, and of course the bile from the liver and gallbladder. And so that's why when people are starting to get all-round digestive problems, it typically starts with the fats. They say, oh, fatty foods don't agree with me. Or that. So what I do at that point is to probably give them a short run of intravenous phospholipids and so forth, which is basically a kickstarter to the hepatobiliary excretion system and the general liver function. And Good. The bile has two roles. One is the excretion of toxins and so forth, and the other is the digestion of fats. And so you kickstart that, and after maybe the second or third or fourth IV, they start to get a bit of churning. So then they have an almighty clear out, world falls out of their bottom, and then you say, yes, the hepatobiliary excretion route is now working again. So,
Thank you very much. Thank you.
Sorry.
If you don't have a gallbladder.
Give me the question again.
You don't
Oh, well, you'll still be producing the bile. You just don't store it and or concentrate it or leave it there. So, I mean, that can be a problem. I've seen a couple of people who have had toxic reactions, who had their gallbladder out, and then they've had an overstimulation of the biliary excretion, and you get an almighty nasty thing when it comes up upways rather than going down. So it can be a problem.
Great. Thank you. I want to carry on with, this is all kind of one set of Zoom questions for Dr. Myhill, and then we'll come back to the live audience. This is a simple one, Sarah. What's the reason for taking iodine specifically at night?
Because iodine and vitamin C both kill microbes, but they kill in a different way. So vitamin C is an oxidizing agent and iodine is a reducing agent. So if you take them together, they knock each other out. So take them separately. And before we advance any further, I cannot believe we got this far in the course of the day and nobody's mentioned vitamin D, which is a vitally, and that's your fault, Damien, I think, which is a vitally important anti-inflammatory. Everybody's deficient. We should all be taking at least 10,000 IU of vitamin D daily.
Yep. And as Damien reminded us at a recent conference, our microbiome bugs can't make it for themselves, so we need to make it for them as well, just like they make B vitamins and vitamin K for us. Okay, another question for Sarah. It's all part of one question. What if does a high-fat diet, high-fat, low-carb diet encourage endotoxin translocation from the gut? I mean, you're going to say no.
No, it does the opposite. I mean, the main nasty toxins come from the upper fermenting gut, and the friendly microbes in the lower bowel do not create such toxic metabolites. So no, it's the treatment form.
Right, and I think this final part of the question, you're just going to say, just do it. And it says, can we have your opinion on how to recommend the PK diet as we are non-medical professional?
Just do it. Well done. Yeah, well, thank you very much. It's made my job very easy.
You had a question. Oh, sorry, Damien.
Sorry,
go ahead.
I just want to ask Sarah yet another question. Do you think that the upper fermenting gut provides an explanation and a solution to the patients who say, oh, I'm so sensitive to supplements, 6 months in, I've got up to 10 milligrams of B6 a day, that kind of thing?
That may well indeed be the case, because microbes, from an evolutionary perspective, our mitochondria derive from microbes. So what our mitochondria are hungry for, these microbes in the gut are going to be hungry for as well. And so, of course, they're going to love all the minerals and the vitamins and the mitochondrial support in the upper fermenting gut. And yes, you may well make that worse by taking the mitochondrial support before you've done the PK diet and cleaned out your upper fermenting gut. So absolutely yes, Damien.
Great. Thank you. You had a question.
This isn't actually a question so much as a comment, if I may. I've worked with people with different types of metabolism and diet for particularly the last 20 years in cancer support. And a lot of people definitely do respond to a ketogenic diet. There is a subset of people, in my experience, that do very badly on a ketogenic diet and do need to go on a more more what we might call vegetarian type diet without the high fat, and you can reverse them. And there's no point in trying making them ketogenic types. And I think if we keep in mind that we are treating unique individuals rather than everybody, we can avoid a lot of these questions. Thank you.
Absolutely. Thank you. Now, as far as I know, I've asked all the Zoom questions, but can you let me know if others come through? And meanwhile, let's carry on with the people in the audience. Yes, go ahead.
Dr. Myhill, do you avoid giving iodine to patients with Hashimoto's?
Hashimoto's.
Did you say IVs?
No,
Iodine.
No, not
Sorry,
at all. Not at
no.
all. I mean, yes, the iodine is essential for the thyroid gland, but iodine is essential for the immune system, for muscles, for heart muscles, for the brain. You know, it's a hugely underrated nutrient, and most people, if you're not taking iodine supplement, you will be deficient, and not many people have what's called iodine sufficiency. But no, it's absolutely totally desirable. In fact, Dr. David Derry will, in a paper, tells us that iodine deficiency is the cause of autoimmune disease, not iodine, not an excess of iodine. So no, totally desirable in Hashimoto's.
And with regards to supplementing selenium, do you ever test selenium? If so, how do you test it?
Well, when I was doing the mitochondrial function tests with John McLaren Howard, we would routinely measure glutathione peroxidase and glutathione, from which you can infer selenium levels. And again, selenium deficiency is almost pandemic, simply because the soils are deficient. And since we joined the European Union, so all our grains come from Europe instead of Canada, it's got a lot worse. So yes, we should all be taking selenium, and I think the RDA of 100 micrograms is probably insufficient. And I reckon at least 200 micrograms daily is the bare minimum for selenium. But again, for it to be absorbed, you've got to have a non-fermenting gut. Back to square one again.
Okay, thank you. There was a question somewhere at the back there. Yes, lady at the very back. Thank you. Just keeping you busy, Rachel.
Absolutely. Daily exercise.
Could you give some guidance on FODMAP diets for patients that we're seeing? You mentioned it briefly, just about basic protocol and how you're sourcing whether you're using antibiotics, the neomycin and the rifampicin.
So I didn't catch the second bit. So it was information on the low FODMAP diet and
the antibiotics, sourcing the antibiotics, if you use them alongside or not.
I do some. You mean if there's something else happening in the background, if there's SIBO, if there's so yeah. I mean, low FODMAP. You know, I use it for a lot of my patients. You know, I've noticed it helps. I'm no expert on low FODMAP. You know, it's a diet that I found it helps. It has a sort of a low inflammatory, as well as, you know, SIBO, which tends to be a big one as well. With SIBO, yeah, I mean, depending, you know, usually, you know, if I get a referral from sort of nutritional therapist, they've already tried herbals. It hasn't necessarily, you know, in some cases it doesn't necessarily work. In most cases, I guess it does. In which case we might use an antibacterial that doesn't sort of absorb something like rifaximin, which tends to give good results. But yeah, you know, tie that to the diet and just reduce sort of the inflammatory burden and the toxic burden, and you know, even if it's taking gluten and lactose out. And I guess I'm going to be using a lot of keto diet as well with my patients now. So, but yeah, it's something that has worked with a lot of patients as well. So,
thank you. Okay, here's a question for Dr. Myhill. Would you use glutamine to help heal the leaky gut?
Well, glutamine is the most abundant amino acid, and if you have a reasonable amount of protein in your diet and you're digesting it well, then it shouldn't be necessary. I think people have a lovely idea of glutamine somehow blocks up the holes in the leaky gut, but I don't think it's quite as simple as that. Right. So I don't particularly use it, I have to say, but I don't know if anybody else has any experience or...
You sometimes see people who it really makes a difference to, but not on its own anyway. That would be you know, that would be done. And the other thing that's you know, that's strikingly good for leaky gut and so there's the zinc carnosine, of course.
Thank you. Okay. Yes.
It can also accentuate neurological issues. So if you've got a patient who's got PANS pandas, for example, obvious, you know, leakage through the blood-brain barrier, then I think one has to be careful. And also in cancer patients, if there's signs that their cancer cells are being fed by glutamine, then that's something very specialist, and it's probably worth checking that as well.
It's excitatory. I mean, we have a lot of questions saying, should you prescribe this and what do you think about the use of that? And it's a package, isn't it? It's everything. It's never going to be one intervention because these things are multifactorial in cause and they need multiple help. Okay, question for the whole panel, 3 questions. About ozone, via colonic application, or is it best to have the whole blood circulated through the ozone?
Well, it depends. As a practitioner, you have to be selective, and the application way is important. So medicine always has to be individualized, as we just heard with ketogenic diet, for example. There was a question about cancer and glutamine stimulating glutamine pathways or blocking them, but we cannot, for example, just give ketogenic diet to all melanoma patients where it's contraindicated. So it has to be individualized. And in this case also, you know, some patients, you have to have either a good chaperone policy as a practitioner if you do ozone, rectal ozone insufflation, or patients mostly use it at home. In home kits, it's much better, but it's then their own responsibility how they use it and follow the instructions and get a practitioner to advise them correctly. Intravenous ozone, as I said before, it needs good venous access. There's similar gadgets use photodynamic therapy that creates ozonides, which is a bit easier, a bit less time consuming, and also easier to apply. But I think we covered this question mostly.
Yeah. Okay. The same person, who I know is a very experienced practitioner because she's put her name here, could you comment on the use of quinine? Anyone on the panel want to comment on the use of quinine in long COVID? No? Okay, nobody's got any experience of that. And lastly, would you consider long COVID? Oh, did you want to?
It's a pharmaceutical.
It is used in malaria.
I'm not an expert, but I just, you know, so quin is a pharmaceutical malaria. It's an anti-inflammatory drug. It's used in homeopathy. There has been a track record of using quinine supplements to help in cholera situations. Yeah, what was the question?
Would you comment on the use of quinine in long COVID?
Yeah, I mean, there's a lot of tonic water used, and
yeah. Go on.
Yeah, well, I'd like to ask you maybe. I mean, I've probably got more experience of quinine and so forth than a lot of people because I've worked in tropical countries with malaria. But I mean, I always used to think that it just killed the bugs, but it's now looking as though quinine, chloroquine, hydroxychloroquine, they're ionophores. They help to transport zinc into cells and thereby support our own immune systems in dealing with the virus. Am I right?
Yes, of course. You're right. And hydroxychloroquine is also used in rheumatoid arthritis as a licensed drug. Try to speak louder. Hydroxychloroquine, which is often comes up in the headlines, and many practitioners use it. The official license is for rheumatoid disease. So many elderly patients, rheumatoid arthritis patients, have stacks of hydroxychloroquine in their kitchen cupboards. Without knowing it, they would have also helped them, funny enough, or maybe unknowingly helped them to get through the pandemic crisis more easily for that reason, for that mechanism. And it's used often as a first-line treatment. We cannot officially say it's a treatment. You just basically treat cytokine reactions, but we cannot say officially we're treating more the laboratory parameters rather than a syndrome. So we have to be careful.
Thank you. Another question from, yes, lady in red.
I think this lady had a question first.
Okay.
If you're still watching.
I wonder if you could enlarge a little bit or expand on the question why ferritin in particular goes up with long COVID. I haven't quite understood that.
Why does ferritin go up in long COVID?
One of the actions of the COVID virus is it splits iron off hemoglobin. And that's why you get the low oxygen levels in the blood. It's a little bit like malaria, it does the same thing. You get the low oxygen levels in the blood because that's the effect that the virus has directly on hemoglobin. So by contrast, then of course, ferritin increases because there's all this free iron swilling around, and free iron swilling around the body is very dangerous because it's very pro-inflammatory. So the body tries to mop it up as ferritin to get rid of it. But of course, a high ferritin is an inflammatory marker in its own right. So what stops that disassociation is vitamin D and vitamin C, highly, very, very important in acute COVID. And one of the big mistakes that was made in the epidemic of acute COVID was people being told, oh, do nothing, wait till it gets really bad before you take yourself off to hospital. We now know that is absolutely the wrong advice. You know, with acute COVID, we should be diving in early with vitamin C, vitamin D, rest, you know, antioxidants to stop it progressing. And those interventions in place are highly effective and prevent the COVID progressing. But it's a oxygen ion dissociation issue.
Thank you. Very important example of how it's not how much of a nutrient you've got, but where it is in the body. Is it in the right or wrong compartment? So you can have excess and deficiency at the same moment. Could you pass the mic to the lady on your right in red? Oh, thank you.
I just wondered what the panel thought about Nigella sativa as an ACE2 blocker and using it as a prophylactic, perhaps.
Yes, I'll be mentioning that this afternoon. I found it extremely helpful in quite large doses. Sometimes patients, it's actually recommended by the FLCCC, if you know that, the frontline doctors, as an alternative to some pharmaceuticals that are problematic in prescription, or for nutritional therapists, naturopaths who want alternatives that are natural, and it seems to be extremely effective. In certain cases, I have had patients who've got MCAS, you know, histamine intolerance, and they've found after a few weeks that it's no longer tolerable. So that it may well be a histamine releaser, a little bit like N-acetylcysteine, interestingly. There are studies that can also be intolerant after a while for people who are histamine sensitive.
Thank you very much. All right, there are more questions on Zoom than we're going to be able to get through. So what I'm going to do is miss out those questions which have actually been answered in the presentations already. But one quick practical question for you, Dr. Bendy Abdallah. What dose of melatonin do you recommend for reducing neutrophil response?
Yeah, so
we have done that one as well.
Similar, 3 to 5 milligrams usually is where I try to aim.
All right. Is the chair allowed to ask a quick question of the panel? Because I'm aware of a number of pretty healthy young people who've had COVID, who have not got long COVID, but who haven't got their taste and smell back, and they're already taking zinc. Anyone got any suggestions?
Yes, I'm going to mention this afternoon, but maybe I'll go shortcut it here. Tom Levy, who I've worked with to some extent, recounts that he got the COVID back in about October. Quite bad. He said it's the worst and more sick than he'd been for 20 years. I think it was a bit affronted, but you know, how dare it do that? And part of that was that he completely lost his taste. And so after a couple of days when I couldn't manage to do it, he decided to give himself some intravenous vitamin C and stuck a needle in the arm, put 25 grams in slowly. And he put because he always gets thirsty when he's doing that, but because of the vitamin C, he had a root beer, whatever that is, to drink. And took a sip before drinking it, couldn't taste it at all. After a few grams of vitamin C, took another cake and it was better. And by the end of the infusion, he'd got his taste sensation back completely.
Wow, okay.
Did it last? Yeah, I think it did actually.
Okay, there is one question that's for you, Damien, which is what about the risk of overdosing on vitamin D?
Well, you have to darn well work at it. Really, I would say the upper limit of complete safety is 36,000 international units per day for 3 months. If you exceed all of any of those, you're at risk. That doesn't mean that you're guaranteed to get a problem, But you know, stay below that, and really there's no great reason to go above that dose anyway. You're not likely to get more benefits from it.
And just one little thing, very often people have their vitamin D level measured and they're told, oh, it's too high.
Yeah.
Well, there is no such thing as a too high vitamin D. Yes, it can raise your serum calcium, and that's the only manifestation of toxicity of vitamin D. So check the calcium. If the calcium's fine, then you are not overdosing with vitamin D. It's extraordinarily safe stuff.
Okay. Thank you. One more question from the audience and then we have to finish. Yes, go ahead.
Hi, this is for any of you. Have any of you seen a decrease in a deficiency in folate for anyone who's had COVID or long COVID?
Anyone seeing folate deficiency?
The reason why I ask is I did, and I researched and I went to look to see what researchers had been done about it, and it was I didn't really understand it, which is why I wanted to ask, but it was something to do with the virus mopping up folate for replication. But I was wondering whether anyone had seen that and whether that had been anything you've used.
It seems to be very good evidence for B vitamins, and particularly as long as the patient tolerates the methylated B vitamins, and that would include methylfolate. I mean, obviously one has to go gently, and pantothenate, you know, vitamin B5 seems to be particularly useful in COVID, long COVID as well, but I'm not sure about folate alone specifically. Just part of the methylation cycle, exactly. Yeah.
Yeah, I think I'd give the same answer really. I've seen people who one of the causes of their long COVID seem to a severe disruption of the methylation cycle, and obviously folate feeds into that. But no, I would say.
Oh, yeah, it might also be interesting to measure homocysteine at the same time, measure other parameters.
Yeah, indeed. All right, well, panel, thank you very, very much indeed. The panel will be coming back at the end of the afternoon session, so there'll be another Q&A.